Yeah. So we have a left upper quadrant, and you should rank this picture. Is the patient position correct? Is the probe correct? Is the amount of gel correct? Is the pressure correct? Is the depth correct? And is the gain correct? Du koppelst nicht ab, aber so ist. Okay. So the patient position, yeah, it's medium. Optimally, you want to keep the left arm above your head to open up the intercostal spaces. The probe is correct. We want to use a curved array for the left upper quadrant. The amount of gel was correct. The pressure was not that great because we lost some signal cranially. You want to apply enough pressure so that you get the whole image. The depth, oh, can you maybe just switch back to the ultrasound image? Yeah, we are losing a lot of resolution there. I'm just going to freeze. So all of this space, yeah, all of the space on the bottom of the screen, you're losing the resolution because you're seeing the spine, and everything below that is just table. So that's none of our interest. And the gain was also a little bit too high. We want to see clearly the structure of the organs that we're interested in. Why is the gain so important? Because like if you oversaturate your image, you're not getting enough contrast. Okay, next question. Is this pelvis male or female? So, I'm very impressed. Great job. 92% got it right. You're seeing the uterus behind the bladder, and like in comparison, there's a male pelvis, no uterus, of course. Okay, now we're going back to the live image. Frozen. Julian is gonna image a right upper quadrant. Yeah, and from this image, how should Julian move the probe to visualize the caudal tip of the liver? One of the most important parts in the eForest exam because it's the most sensitive area for small amount of fluids. 30 votes. So let's look at the votes. Yeah, correct. He should move caudally. Because when we switch back to the live image, what happens when he switches, he moves caudally? Yeah, now we're moving towards the caudal tip of the liver. If you move cranially, you're going to see more of the thorax. That's not the region of interest in this example. Moving dorsally doesn't affect if I image the caudal tip of the liver, and neither does ventrally. So we're going to move on. You can put on the device a pin down. Where is the interventricular septum in this peristernal long axis? Oh, wow. Yeah, that's correct. We're having here the right ventricle, the left ventricle, and in between, of course, the interventricular septum. This structure here is the aortic valve, and this is the mitral valve, or some peppermary muscles. That we would have to interpret that on a loop, not on a still image. Great job. Okay, a slide got lost there. Huh. Okay, no, I don't know why there got a slide lost. Okay, we're moving on then. So from this loop, how do you need to move the probe in the parasternal long short axis to visualize the aortic valve? Let's look at the results. Oh, you're really good. These questions are too easy for you. Yeah, you need to move towards the base of the heart, because when we go to live image, please. Starting from the mitral valve, and if Julian moves his probe or tilts his probe towards the base of the heart, then we're going to see the aortic valve. In contrary, if he moves or tilts the probe towards the apex of the heart, we're going to see only the papillary muscles of the left ventricle. If you start zurück zum Mitralklappe. If he moves his probe towards the sternum, then you're just going to see more of the right heart, but if it's too far, then there's just bone and you're not going to see anything. And if you move to the left shoulder, then just the lung will cover up the heart. So that's not any helpful. Okay, the slides just got mixed up. No, it's not gone. So if you see this loop, how would you estimate the left ventricular ejection fraction? Roughly, it's not like 1 or 2%, it's just roughly. Because we're talking a lot about eyeballing and just guessing if a patient got his problems from his heart or from his lungs. So how do you estimate the left ventricular ejection fraction in this image? Oh wow, it's all over the place. And that's exactly what I suspected. Because for untrained eyes, it's really difficult to estimate the ejection fraction just from eyeballing. And that's one take-home message from you, just because now you know the basics, you don't know the interpretation. I don't know the interpretation either, because this is like, it's a heart from my colleague. It's just a perfectly fine heart. Okay, and now we're going back to the slide that was here. That just got mixed up. That is a really bad ejection fraction. So just in comparison, okay. Again, you can click a pin down on your device. Where is the plural line in this M-mode picture? Okay, let's see. Yeah, that's great. It's depicted twice, of course. It's depicted here in the B mode image, and then again in the M mode image of, it's this hyperechoic line. These lines, these are a muscle of fascia. Really good. Now you can type in some responses. I'm really interested to see what you've got. under which circumstances does the pleural line that we've just seen does not appear to be moving? Yep, pneumothorax, of course. That's the whole thing why we're doing it. What other causes are there maybe? I see apnea. That's of course right. Either because the ventilation is blocked, for example, for a foreign body, or patient is dead. And the pleural line does not move at all. Pneumectomy or pleurodesis, that's correct. Either surgical or post-inflammational. If like I got the fibrothorax, the pleural lines, the pleural fascias, they don't move it well as well. And in severe emphysema, if the patient just breathes very shallowly, then it can be appearing as not moving, but then the M mode normally helps. And there are two things that can distinguish the real pneumothorax from these other causes where the pleural line does not move. Because if we got B lines, these are the lines that you get vertically, beginning from the pleural line. It's because of fluid accumulation in areoles near the pleura, and they only exist if the pleural lines are matching. If they are dehiscent, like in a pneumothorax, B lines cannot form. And the lung pulse. I guess the tutors will go through that in the hands-on sessions with you, the lung pulse. So we're going back to our live image. And Julian is going to find a vessel for us. And I want to know of you, is that the IVC, the inferior vena cava, or is it the aorta? Yeah. Okay, you're really quick at that. That is, of course, the IVC. If you're going back to the live image, yeah, you've got this double pulse. It's pulsating twice every heartbeat. It's sorry. Yeah, it's going towards the right atrium. So it's now on the left side of the screen, and Julian is going to depict the aorta at the right side of the screen in comparison. The wall of the aorta is, of course, thicker. It's more muscles. It's not going towards the right atrium, but dorsally of the heart. Yeah, there you can see it really, really nicely. So there's the aorta, and the IVCs are going directly into the right atrium. Okay, then we can move on. It's more a theoretical question. Which of these imaging technologies or other methods should I use to diagnose or diagnose a deep vein thrombosis? Ja, beim nächsten Stück Sie warten. Beim nächsten Sie warten, das sehen Sie das direkt. Ich zeige jetzt das nicht. Das kann ich noch sagen. Ja. Sehen Sie das direkt. Okay, great. Nice. So let's talk about the algorithm in case you've got, you think your patient has a DVT. First of all, you're going to do a well score. You're going to estimate the likelihood that the patient is having a deep vein thrombosis. And if you're having a high likelihood, you're not going to do any D-dimers because you have to do a compression ultrasound anyways. So the D-dimer does not affect your algorithm. You don't have to do them. If the likelihood is really low, so well score 2 or less, then you can do a D-dimer. If the D-dimer is of course negative, if the D-dimer is negative, you shouldn't do any further imaging. If the D-dimer is positive, you should do the state-of-the-art compression ultrasound that you're going to do or already have done in the hands-on sessions. And further imaging, for example, with MR angiography, is not primarily recommended. Only if the compression ultrasound is like inconclusive, or if you're like preparing for an operation, then MR is indicated, but not primarily. In this image, or in this loop, do you see a left leg or a right leg? The probe marker is in this case the yellow blinking image. So we are at the height of the great saphenous vein, and we're doing compression ultrasound. So is it the right leg or the left leg? It's the right leg. How do you know that? Any comments? Why did you choose right leg? Okay, it's a trick question. You can't say it from this image. And we're going to see why. If you're going to tune to the live image, because you don't know where the probe marker has faced on the patient. Julian is going to now scan the right leg with the probe marker laterally, so that we get the image that we just saw. Okay, yeah, you can freeze. That's the image we just saw. Right leg, probe marker laterally. But if he's going to scan the left leg with the probe marker also laterally, it's just going to be the same image. So always document your still images correctly, so that everyone who did not see the image being constructed can also identify it correctly. You see? Other leg, same image. And that is it. I want to end with a citation from the Ultrasound podcast. I really like this because I would like to motivate you to just get out there and use ultrasound. And even if you're not quite sure what you're doing, you're getting better by doing it, and you're not harming your patient. In so many wards, there is some ultrasound machine like in the back of the latest room. Just grab it when you're like doing practice or clinical rotations or something, and use it. Okay, then thank you. Here are some recommendations. Just some recommendations for the grad students. You can borrow the butterfly IQs, the handheld devices from the library. You can also revise your knowledge with this e-learning. And then there are some English stuff. Is some English stuff as well. 5 Minute Sono is a really quite great YouTube channel. They also produce the Ultrasound podcast. It's a bit more in depth, but the 5 Minute Sono is really great for getting like getting into a specific topic shortly. And the POCUS Atlas is really great if you're searching for pathologies and to just see them sometimes. Okay, thank you.